to welcome again Jane Duffy and Rachel Smith, who are going to be presenting tonight. And we're on part 2 of 4 webinars, and they're going to tell you all about them. And then later on, I'll put a link into their website into the chat after the demonstration, and also links to the slides and our newsletter list and that sort of thing. So should you be looking for that? Okay, so I'm going to hand you over to Jane and Rachel now. Thank you.
So for the people who worked with us last week, I'm Jane Duffy.
I'm Rachel Smith.
And we're both physiotherapists by background. And this week we're going to be, can we have the next slide please, Caro? Okay, so sorry, last week we had a bit of a refresher around balance and falls and explained our clinical experience into why we decided to develop Balance Active, but also not just looking at that, but the actual process of developing it as well, because it's quite a unique thing for therapists to become involved in actually from scratch to final product in terms of getting something to market. Now this week, we want to introduce you to it in more detail, so the actual nuts and bolts of it. We're going to demonstrate how to put it together. We're going to be demonstrating how you can use it. And we're also going to be asking you to think about how you think you could use Balance Active in practice as well. So it's going to be a sharing is caring session again. So if we have our first slide, our next slide, please, and we can tell you what's in the box. So for those of you, again, who weren't here last week, and for those of you who were, the actual Balance Active unit itself comprises, it's modular. And so that means it's very easy to transport. There's a non-slip base plate. There are 4 leg extensions, which will demonstrate the use. You'll see the use of it with the leg extensions and without the leg extensions. There's an adjustable knee block. There are the uprights, which the adjustable knee block slots onto. 2 light touch uprights, a carrying bag, and some user instructions. So that's the kit and caboodle. Now, we've been playing at filmmaking this week, so our next, we'd like to share our first video, and this is literally just what's in the box and putting it together. So when you're ready.
Plate, the non-slip base plate. You can see the carrying bag there, so it's easy for one person to manage. To transport. It fits in a car. We do know some people who use it on buses. So these are the legs. You'll see that there's a little clip mechanism on there that you'll be familiar with from walking aids, and these literally just clip into the base plate as like so. You'll also notice that on the end of the feet, the extending legs rather, there are some little rubber feet, and that helps again give another anti-slip surface and takes any wobble factor out of things too. So once you've got your 4 legs in, then you can start to pop the uprights in. You'll see again these have got a similar mechanism to the feet in that they're just a pin operated device, and they literally attach into the base like so. You'll also notice on there that they've got holes up the length of them, and that's so that the knee block can be adjusted for different sizes of people. Now the adjustment and specifications are on the general population, so they will go to quite small people up to really quite tall people. We haven't had this tested yet with children, but there has been interest from paediatrics, and so that's something that we'll be keeping you up to date with. But actually for fairly tall kids, it does work. It just means that you've got to take that extra precaution in terms of your assessment. So you'll see that those fasten into the uprights with a peg, and it's a pretty straightforward procedure. So there's your knee block, and then just to top it off, you've got your light touch handrails here. And like we said last week, if you remember, these are designed literally for light touch and not as a weight bearing surface. It just gives service users a little bit more confidence when they're on the apparatus in terms of another surface. And there you can see Rachel's on it now and giving you a demonstration of the right setting for her, but also look how far she can actually go, literally. it's not going to tip. So in the bag as well, there are some user instructions, okay, which we'd want you to always be familiar with before.
And the all-important CE mark.
Exactly. So that is what's in the box.
Next slide, please. So we don't think we'll win a BAFTA, but we hope it gives you the basics of how to put it together. It is a very simple process. So then, Rachel.
So, having seen the unit and seen it put up and seen me just demonstrate that really you can't tip it over, or certainly you can't fall over the top of it, what can you actually do with it? And for those of you that were with us last week, you'll hopefully remember that we were talking about balance really being impacted upon by leg weakness and trunk weakness, but also that balance is quite a complex skill. And when we talked a little bit about motor relearning and skill acquisition, that you can actually, with practice, start to improve your balance. And that's what Balance Active's for. It's about actively standing and balancing. So the sort of activities you can actually undertake with Balance Active are all geared towards improving balance, but also about recruiting postural muscles and some of the leg muscles, because obviously you're in standing, and that will help counteract things like deconditioning. So obviously one of the first exercises you can do on Balance Active is literally just stand. And now if you imagine that you have had a stroke or you're really, really unsteady, just standing there on it, knowing that there's a knee block there that is actually going to prevent your legs giving way, is incredibly reassuring for some of these patients, and they can learn to stand. But really importantly, while they're actually standing there, they can start to sort of think about what can they feel, what does their body actually feel like, where can they kind of sense where the weight's going, can they sense what the feet are feeling like, what the joints are feeling like, can they sense whether they're upright or bent forward. So it can be a really useful tool to start to get that, just that basic standing. And you can then, once somebody's fairly comfortable standing, you can then start to progress to do other things. Now, one of the really useful things about Balance Active is it means you as the therapist are not having to actually hold them up or block their knee. They are standing, and it means you as the therapist can go to the side of them or even go behind them and actually observe how they're standing, whether they're symmetrical, where the weight's actually going. So that's really useful. Now, I just want to point out, and I hope you've noticed this, that these exercises are not in any hierarchical order. We've just put down a whole series of things that you can do. So it's not necessarily you just stand and then you'd stand and weight shift. They're not in that sort of order. But obviously, if you can remember last week as well, we were talking about people with stroke and the evidence for undertaking dynamic weight shifts post-stroke as a means of evidenced treatment to improve walking and gait speed. So you can stand and you can then start to shift your weight side to side. Really important as one of the elements of gait. It's one of the critical components of gait to be able to do that. You can stand and you can start to think about altering the base of support, and that could be by standing with your feet much closer together. You could have your feet much wider. You could stand asymmetrically. You could start to stand and go up onto your tiptoes, for example, making the base of support really small, but you're also then actually bringing in some strengthening of things like your gastroc and your soleus. So you can do lots and lots of things with base of support. You can stand and start to incorporate upper limb activities. And again, if you think back to what we were talking about in terms of balance last week, when we were saying it's an anticipatory mechanism, so that if you decide you're going to move your arms, before you've moved your arms, your back muscles will activate in order to counteract moving your arms and shifting your base, your centre of mass forward. And so actually standing and doing lots of upper limb activities, be that raising your arms up above your head, is actually starting to be an early way of getting you to relearn some of those basic balance mechanisms. So you can do that. You can stand and turn your head, or stand and look over your shoulder, and that will start to stimulate some of the vestibular system, but it'll also start to be a very early way of getting a subtle weight shift without actually really having to shift your weight or consciously start to think about shifting your weight, but it will shift your weight. You can get people to reach, you can get them to reach forward, you can get them to reach laterally, and in doing so really start to shift their centre of gravity, the centre of mass, right towards the edge of the base of support, depending on where you're trying to progress them. You can then start to do quite dynamic things on Balance Active that starts to bring in basic reactions, coordination, speed of movement. So things like throwing and catching, and we've got examples on videos of some of these. You can do stepping. You can get somebody to step back, step forward, which again is sort of progressing the lateral shifts. And then you can do more what you'd consider to be potentially more strengthening type activities, so things like small knee bends, although they are also targeting balance. They're starting to recruit quads and glutes and hamstrings and calf muscles, so you can start to strengthen doing that. But you could do that with a small weight in the hands, for example. And then some people have actually used it for dynamic stretching as well, so getting into a functional standing position and really standing upright to stretch things like the calf, and to stretch things like the hip flexors, and there's a video showing that coming up. So it's really dependent on what that person's presenting with, where they're at in their treatment, and what they need in order to challenge either their balance or their strengthening. So you can do all sorts of things. I don't know, do you want to add anything to that?
I think that's great.
Okay, next slide, please. So the next 3 slides that we're going to show you are actually videos. So they're just demonstrating really basic things. So here you'll see somebody standing on Balance Active and they're doing an upper limb movement. So this is where they are really having to recruit the postural muscles, so the back extensors. They're going to be recruiting the glutes. They're going to be recruiting around the ankle in order to counteract that upper limb movement. And it's an early way of starting to get some balance rehab going on. Now that could be progressed by using things like resistance band, or by using weights that just put more force towards the front, so that the centre of mass was being brought more forward. And there she's demonstrating, as we were saying before, turning the head, which is going to start to get the vestibular system activated, but also she's actually turning her whole body. So she's managing to get quite a significant weight shift on the leg towards where she's turning, which is really helpful in this early, can we get a weight shift? Now, some patients would potentially start just by moving their eyes, or they might start just by a really subtle turn of the head, because even turning your head is going to start to shift your centre of mass. But that's just a demonstration of some of the sort of early exercises, but they're still dynamic and they're still active. She's actively having to stand and recruit those muscles in order to balance. The beauty of it is she's got that knee block that gives her the confidence that her leg is not going to give way as weight goes onto it. And again, you can get people to think as they're moving, what's that actually feeling like? Can you feel that weight shifting? Can you feel certain muscle groups starting to be activated? And that can be really helpful for people to then go away and start to visualize those movements when they're trying to train. Next slide, please. So the next one's another video, and this is really demonstrating lateral weight shifts. So when that starts to play, you'll see she's really starting to shift her weight from side to side. Really important as one of the critical components of gait. You've got to better get your weight onto one leg in order to swing the other leg forward. So it's a really good starting point, and safe starting point. Now she's managing to shift her weight quite significantly from side to side, and she's just demonstrating how you could progress that to start to take one leg back. So she's almost doing a back step. But what you could get her to do is stop in that asymmetrical position. So she's in step stand, and see if she could balance there. And again, get her to think about, what does that feel like? Where's the weight going? Can you tell? What can you feel through your feet? And progress that again. You could take that progression even further and have her in step stand and get her to turn, look over her shoulders, or move her upper limbs. It's dependent on what is needed. And
I think the beauty for us is that as therapists, you can stand back and really appraise and scrutinise what is working, what's not, and give that feedback to be able to correct that, so that people are actually getting the feeling of what does good feel like, what does the correct position feel like. And so again, like Rachel says, it's the confidence, and absolutely
get them to then feedback to you
exactly how that, and observe the difference. So
okay, so the next one is actually quite an advanced activity. So this is where we're talking about reactive and being able to coordinate and rapidly move. So this is throwing and catching. So this would come later, but you'll see she uses the light touch support there, because she shifted her weight so far back, she just corrected herself, which is a normal reaction. We talked last week about the different balance strategies we've got. She was demonstrating her upper limb strategy just to light touch, but she's maintaining that lovely upright position, and she is able to shift her weight and twist and turn. So that'd be a much more advanced activity, but you can kind of hopefully get a flavour of, from quite early on, basic standing with upper limb movement, through to weight shifts, through to dynamic activity, just as a flavour for what you could do. So next slide, please. I think we're going on to frequently asked questions.
Right then. So as we've developed Balance Active, and as we've been taking it around, these have been some of the common questions. So we thought we'd do a little bit of a question and answer session now. I hope you know the answers, Rachel.
Well, you do if I don't.
Well, that's all right then. So we wanted to just share these with you. So anything else that you think of, though, as we're going through, obviously, like Carol said, make a note of them, and we'll talk about them at the end. So, Rachel, what's the maximum user weight for Balance Active?
So the maximum user weight is 100 kilograms.
Okay, so it's quite a sizable person that can use that then. That's brilliant, thank you. And how much does Balance Active weigh itself, you know, when you've got your bag and your base?
So the whole lot together, bag and base, is only 10 kilograms. And it was designed like that because we wanted it to be a modular portable piece of equipment, so you could take it around quite easily.
Okay, so within manual handling limitations.
And hopefully from the video that you just saw of me putting it together, hopefully you could see it wasn't that difficult to carry and manoeuvre and put the base on the floor and put together. And
that's important, you know, when you're thinking about yourselves, you've got to think what's the impact's going to have on you too. So that's why we've made sure it comes in at that weight. And we did see the little holes, but just to be absolutely clear, is Balance Active adjustable?
Yes, it is. The bit of Balance Active that's adjustable actually is the knee block, so you can move it up and down to fit different heights of person, basically, or different leg lengths of person.
And I think it's just worth mentioning as well about the adjustability of having the legs on, the base legs on and off. Because when we get to week 4 and we show you some case studies, then you'll see how when we've put in different settings for different purposes, how sometimes it's absolutely fine to take the legs off. So you have got that option to reduce its base and the knee block. So can you use Balance Active with different patients then? Is it single use?
No, we designed it so it could be used with different people. Anyone who needed a balance or balance comes strength, postural stability rehab. So yeah, it can be used with a whole range of different people as long as you clean it.
And how do I clean Balance Active then?
So it's been designed, the main part that needs cleaning obviously is the knee block, because that's mainly where the person's going to have contact, and the base plate. So it's cleaned with 70% alcohol wipes, so the usual sort of wipes that you get in the hospital, and that has been shown to be sufficient to kill most nasty pathogens.
Perfect, thank you. And we've obviously seen about sort of a bit of an insight into where you can use it, but can you just explain your rationale for, you know, the acute and home and so on, please?
So we designed it because obviously we've said it's modular, it's transportable, you can use it with multiple patients. The reason for that is, I mean, we used to be community physiotherapy, so we used to be in and out of patients' houses, in and out of care homes, and we designed it so it could actually follow the patient, so it could follow somebody from an acute setting through to an intermediate care setting, through to home, or be used in care homes. So it's been designed so it can be used anywhere, even into leisure settings actually.
No, that's great, thank you. And the patients we've talked about, I think we want to share, don't we, not about diagnoses, but about how patients present.
It's people, isn't
it?
It's
absolutely.
It's we try and get away from particular diagnoses, because people are not diagnoses, people are people with lives. And so it's somebody who is having problems with balance and or problems with leg strength or postural muscle strength leading to balance and postural stability issues, where it's impacting adversely on their lives. And so it can be used with anyone in that sort of situation.
And I think latterly we've noticed how useful it is for people with fatigue. And those have been some,
right.
again, not to go down, you know, obviously the post-COVID rehabilitation patients, but also some of our oncology patients in recovery. And there's a brilliant case study that we'll be talking to you about on week 4 of a lady in that setting. So try and think of it as the patient, what are the patient's needs? What do they need, as opposed to what's the diagnosis? That's all we'd ask you to do.
Isn't it?
Hope so. So, right then, this is a belter. So, because when we first did this, a lot of people said, well, there's standard transfer age, you can use them. And we were like, well, no, you can't. So, Rachel, would you like to describe the difference between a balance age and a transfer age?
We touched on this last week, because one of the triggers for us to actually start to design Balance Active was that there was a gap, there was something missing. So you either had multiple therapists trying to support somebody, or you went to what you had next, which was some sort of transfer aid. Now, the problem with transfer aids is that they're incredibly passive, and they often require the person to hold on with their hands, so they go straight into an upper limb strategy. So the passive upper limb strategy, and they're often not then getting the person upright in a normal standing position. So the centre of mass is often kind of way behind them. So they can't possibly start to get that feel of what does it actually feel like to be standing upright on your 2 feet and shifting your weight. Balance Active, on the other hand, has been designed and that's the way it's angled slightly forward, so that your centre of mass does fall where it should do, straight between your feet. So it's been designed to get somebody into that sort of position, but encourage them to actively stand. So they're having to recruit postural muscles in order to do that. The knee block is just going to prevent the knee from giving way, so that they feel safe doing it. So there's a world of difference between the two. I think, you know, as our body of knowledge increases and our resources do around videos, we want to try and do some, you know, get some videos of patients on a transfer aid and then into Balance Active, and that's something that we're aspiring to do. But obviously, don't take our word for it. You need to try it for yourselves. But it's important that it's about those critical components to get that range, get that sensation through those joints. So, is training to use Balance Active available? It certainly is. We're quite
By
happy.
Jove.
By Jove, it is. Yeah. So we can offer training remotely, because that's the way things are at the minute. So if anybody wanted to try a Balance Active, we can potentially lend them one, but offer training to ensure that they use it properly and get the best effect out of it. Just get in touch with us.
No, that's great. And I think we'll quickly go over these last 3, because we did allude to this last week. Patients can buy Balance Actives themselves, but they do need to be prescribed by a qualified healthcare practitioner, someone that knows it's the right thing for them. How do you get a Balance Active? Just contact us directly. And like we said last week, the cost is $395 plus VAT to keep it affordable. So low tech, low cost is exactly what we've gone for here. So we're sure there'll be loads more questions. We hope there are, because again, it helps us.
It helps us think, doesn't it?
Absolutely. Yeah. So if we can have the next slide again, please. So we did allude to where it can be used, and one of the things we want to try and get you to think about again is acute settings. Now we've got wards and gyms, but is it really now? We do, you know, we're seeing more and more around discharge to assess, and we think if you've got people in ED and MAU and you're trying to get them home with a package of rehabilitation and care, this would be a fabulous adjunct to that. And so going back to the minimum hands, you know, if you can reduce the need for 2 practitioners in the early days, that's obviously got a workforce implication as well as a opportunity, you know, maximising opportunities for rehabilitation. And again, like Rachel said, intermediate care settings through to their own homes, care homes and leisure settings. So what we're going to show you next are some demonstrations. Now, these are not treatment sessions. These are demonstrations of it being used in different settings. Like we say, when we get on to week 4, the case studies will be much more about the raison d'etre for the treatment, the outcomes of the treatment. But this is just to wet your whistles, really. So do you want to talk? Actually, oh, yes, you know what you're doing with this next bit.
The next slide, please. Next slide's a video. So I'll just give you a really brief, because I won't go into a lot of detail. She's a 76-year-old woman, although she doesn't actually look it. She looks in really really quite young. But she had a hemorrhagic stroke a long time ago, years ago, leaving her with the right hemiplegia. And I'll just let the video play, and then we might play it again and talk over it. But if you just watch it for now, that person just there was a physio. So this is the lady's coming now. All right, can we play that video again, and I'll just point some things out as we go through it. So there's a physio adjusted it, so she knew what height it was. But one of the things is they'd pre-agreed and negotiated where this balance active was going to be in the person's home. And obviously this lady liked having it near that little shelf, because you'll notice her at times during the sort of demonstration, she'll light touch that shelf just to make herself feel steadier. So she's stepping onto it, actually using the light touch handles, which is obviously the way she has learned to step onto it. And she's just moving everything off her shelf there, which is fine. There are things. And at this point in the video, she's got virtually no weight over on that right leg. I don't know if you can tell that, but most of her weight is on this left leg nearest us, until she starts to kind of adjust her feet and use that knee block slightly. So she's adjusted her feet there, and she's going to stand up really tall. So at this point, what she's doing is she's now got weight on both her legs. She's using that light touch handle, but she's getting a really good stretch across her right hip flexor. And this is one of the issues she'd had, is that she was starting to feel a lot of tightness. Now she's just demonstrating some of the things she does there, because she just turned and looked, and she's gone into an asymmetrical stance now. So she's got more of a weight on that right leg. And again, she's stretching her hip flexor, standing up tall, but she still feels the need just to like hold on to the light touch handles. So she's demonstrating some of the things she does. So she gets into the asymmetrical stance, and she's doing some of this rotation. And as she rotates towards the right, she'll start to take more weight on the right, and the knee block's actually giving her the support and confidence to do that. She's adjusting her feet again. And in a minute, she's going to try and move that right leg. And you can see how weak her right hamstrings and hip extensors are, because she struggles. But she's, again, using it to stretch herself and get properly upright. She's adjusted her foot again. Slightly better that time. It's going to stand up nice and straight again, I hope. Or is that the end of it? Oh, that's the end. So what we need to stress here is that was not a treatment session. What she was doing was just demonstrating some of the postures and positions she gets into in order to use Balance Active, and she uses it for around 15 to 20 minutes twice a day. So she gets a really good stretch, and as she goes through that treatment, she starts to better take more and more weight on her leg. And as she says, then this is a direct quote from her, it enables her to put weight on that leg. And I think this is really important because she can then start to get the feel of putting weight on a leg and what that feels like at a hip, at a knee, at a foot and her ankle. And then she can start to progress that, you know, and keep that feeling and visualize in her mind what it should feel like in order to take weight. And she perceives that it's better for her. She can do the exercises and progress herself better. So it's allowing her, in her situation, obviously it's a long-term condition for her, so she's starting to be able to take control and self-manage. And she feels she can walk better around the house after she's been on it. So if you bear in mind, as she got on there, she was quite slow, quite stiff. When she's been on it for longer, she improves and feels that she can move.
And I think, you know, when we talk about the case studies next week, in a couple of weeks, the carryover and the effect on objective markers will be discussed. We'll discuss that, absolutely. Yeah.
So that's that lady. So next slide, I think, is photograph, isn't it? So
right. So this is a demonstration in a care home setting. And last week we mentioned that we've been really lucky to get involved with an incredibly person-centred care home in Bradford. And one of the things that they were really worried about, and in fact, since we've even taken this video, they've had an edict from Bradford Council in collaboration with the health and other social care organisations to really get care homes at this time to think about reducing the risk of deconditioning. Now, this lady, this is her in the activity kitchen. You'll see that the base is off at the front there, so it's up to the table edge, so she can participate in doing something new, purposeful. She is folding napkins there, and you might think, well, whoopee-doo, but you know what? She's much calmer. Her posture's improved. Her gait's improved. Her mood's improved. And this isn't about sometimes, you know, we're not going to see a massive improvement. In fact, she ultimately potentially will deteriorate. But this is about keeping people as mobile and as strong and active for as long as they possibly can be. She lives there. That's her home. She wants to be doing something she enjoys. And again, for the case study, one of the sisters in charge said, you know what, I was sick of hearing people telling this lady to sit down. You know, if everybody's told to sit down and not get up and move, we've had it. You know, it's going to be a crisis time. So the care home, think about it not as a medical intervention, but as preventative, as fun, as part of the daily activities. And there's another gentleman there that's made such a difference too. So it's about thinking outside the box. You know, as therapists or as health and social care professionals, we've really got a duty to think differently about how we're going to deliver some of our treatments during these, these times. But actually, there's be a lot of good comes from this too, in changing our practices and to be thinking about being creative and innovative. And some of the people that don't get seen until it's too late. When Betty can't stand up, then it's too late. So, you know, we need to be in there keeping her on her feet, and she's loving it. Now, next slide, please.
So the next one's just showing an example of its use in a leisure and fitness setting, which is obviously a really normal setting for people to access. So this would be for somebody, again, who's got leg weakness, poor balance, maybe somebody with some of the long-term neurological conditions that impact on their ability to stand and balance. But what it's allowing her to do is to stand actively. So she's recruiting her postural muscles, but undertake some normal strengthening activity that other people might be doing in that sort of gym setting. It's actually a boxing gym, so she was also able to put her gloves on and punch that punch bag there with Balance Active. So it's just got multiple different uses or attributes.
And I think it's opening up opportunities for people to do things in a more normal way. And
things they might like to do. And that's about personalising care. It's about encouraging them to be able to manage their own long-term condition in a way that they want to.
Yeah.
So
we want the next slide, please. And then we're going to ask you to have a little think. So obviously you've listened to us and we've demonstrated. We want you to think now about where you think you could use Balance Active and what sort of service users you could use it with. So we're just going to give you a couple of minutes before we go on to questions. And then I think before we go on to questions, if we could use that chat function to see your thoughts and share those thoughts, that'd be really, really useful. You know, any particular ping moment that you've had and thought, do you know what, I'll use it with so-and-so, so-and-so, this will be brilliant. So yeah, just take a couple of minutes to think about that, and then we'll just interject with some of that discussion via the ladies behind the curtain, if that's okay, before we do questions.
Or if there's anything, if there are any of those videos you want to see again,
yeah,
that's fine. You can show them again,
or you can look at them on YouTube afterwards. Yeah. So if we have the ladies behind the curtain, if there are any people, hurrah, there she is.
I am.
Okay.
We're here from behind the curtain.
Perfect. So if there's anybody got any ideas about what sort of service users or settings, it'd be awesome.
Oh yes.
Hello. I have a lady with ataxia. I could imagine using it for function in her kitchen. She struggles with anxiety and fatigue.
Excellent.
Oh, fantastic. Definitely. And I think, ataxia is a tricky one. So giving somebody that extra,
just gives that extra,
and especially
support.
someone who's anxious and tired.
We've got an example.
Small and often.
One of the case studies we'll do next week is about its use in a kitchen, isn't it?
Yeah, it is. So we'll be able to talk about that.
So I've got a question about sort of building somebody's confidence, because one of the things I was really aware of when I was watching the video was that it must take a bit of a while for somebody to build up their confidence to trust the actual Balance Active. Because I was thinking, this is a completely separate thing, but I went for flotation a couple of weeks ago in a really beautiful salt flotation, and it was interesting how long it took me to go, oh, it's okay, this water is really supporting me. And I was thinking about that as I was watching that video. I'm wondering, on average, how long does it take for a patient to feel confident in that they can actually lean against it and it's going to support them?
It's almost instantaneous, and it's really, it's when the difference, if you think a lot of these people have either been clinging onto a frame, a pair of parallel bars, and have other people blocking the knees, or certainly one of them, to actually feel, if you remember that first video that we showed you this afternoon, when Rachel was on that and showed you how much of a lever she could put onto it, and like once you felt it yourselves, it's almost like feeling is believing.
I think some of it as well is where you agree with the person that you're going to put it, because if you notice that video of the lady who'd had the stroke, that they decided to put that, so there was a shelf in front of her, so that if she felt that knee block wasn't safe, she could go into hand strategy or pulling strategy, and she wasn't going to go anywhere anyway because there was something solid in front. So it's individual. We've got another case study, haven't we, next week about a chap who does use it in the kitchen as well. And yeah, he needed to test it and make sure that knee block was safe for him.
And the relatives. And once the relatives see them feeling comfortable and confident, they're not as worried either, because I think, the challenges of remote rehabilitation and sort of assigning some of the positioning of equipment and supervision of some of the exercises to family and carers, they've got to have confidence in it too. So we've had actually carers and family members stood on it to see what it feels like, so that they can trust it. Trust it. So, and I think you noticed that the physio, who's fabulous from Sheffield Neurophysio, she demonstrated it too. So there's lots of ways to build up confidence by, like Rachel says, choosing the right position that they want it to be in, engaging with family and friends. Demonstrate it first. You're not going to say, come on, Ethel, leap on this and have a go.
It might be that you get them to stand on it and push the knees against it, so that they actually can feel how supportive that is before you then go on to do anything else. So the first session may literally just be getting used to the piece of equipment.
And I was also thinking as well, in terms of you actually also encouraging them not to put it up against a wall, so they are actually getting used to not thinking, oh gosh, I've got to rely on the wall, but they're actually learning to rely on their actual.
Exactly. That's how you can progress some of that activity. So as they start to get more confident and they start to become more aware of sort of the weight shift or where the weight's going, then yeah, you can move it.
I've got an idiot's question because I'm not a physio, so I'm a bit rubbish on anatomy. So I was going to ask you, in terms of the yeah, I'm a bit rubbish. In terms of the positioning of the knee support,
Yes.
can you just give me a bit of idea of why it's positioned where it is and the impact that it has on positioning and gait, etc.?
So it's positioned just below the knee. So it's not positioned at the knee joint. So there's no pressure on the actual patella, the knee joint. It's just below that on the patella tendon, which is a really tough area of your body. But it does stop the knee giving way. So it won't hurt the person, but it will support the knee.
But it's not going to force them into hyperextension either, which some of the stand aids, you're actually blocked into hyperextension, and that makes you flex at your hips. So it does allow you to have soft knees, and that's kind of a physio term. But it, rather than, that people tend to go hyperextend and hang on the hips. Well, once you can get people to encourage them to let the knee go onto that because they know it's safe, then again you get more of that normal feeling. A normal response.
And as somebody progresses, actually, they don't necessarily need the knees against that knee block, but they know it's there if the leg starts to feel wobbly. And I think that's really important because you can progress and they can start to actually take control of the knee as well.
So coming off it, but then if they need to go back on, it's there. Yeah. And obviously you're going to have chairs at back of people if you think they need them and things like that. So if they want to have a rest, but then that's down to the therapist to assess and put in a well thought out plan. So that means they're going to be challenged to the point where it's effective, because actually we undertreat people sometimes, and we're designed to be on our feet. So
I was also going to ask you, for some people it's the and this is about remote more than if you've got somebody, a therapist with you. So I was noticing that you've got sort of a chair, and then somebody's going to get out of the chair and going to get up to use the Balance Active. So how would you suggest that somebody who's nervous about the standing up then stands up to then use the Balance Active?
I think that depends on your assessment, and I think everybody and the person and the circumstance, and it might be that you've got to include it as part of the home care regimes when a carer's in the first instance, and so that it's not a face-to-face intervention by a therapist. It could be an assigned part of another plan. So again, minimising risk of the C word, but also then getting the person to the point where they do become comfortable and confident. Or it might be that actually in that instance they do need a face-to-face to get to the point where they can do it themselves, and then wean them to the point of remoteness. So I think the whole thing about remote rehab, in spite of Balance Active, is about being selective, that we get the right patients to do it with, because some people will absolutely fly with it for some interventions, and some people will still need face-to-face interventions. So it's having that reasoned approach to why you feel, or you've hypothesized that person needs face-to-face and that person doesn't, because it's not a one-size-fits-all. And we absolutely applaud the moving towards remote, but we must remember that there'll be the odd occasions when actually you can't. And we've got to be able to still accommodate that as it within services.
And I think that's why we often sort of use the term blended, because it's really important, isn't it, that you're blending all sorts of different approaches that suit your particular patient or your client.
Exactly.
I was also going to just pick up on the confidence thing, because that comes up over and over and over again, doesn't it? What sort of ideas have you guys got? Because I know it's not necessarily to do with the Balance Active itself, but how do you support your patients to build confidence, and how does Balance Active, if you like, reinforce that confidence?
It's practice, isn't it, in a safe, in what the person perceives is fairly safe, and getting them to, I suppose, be body aware almost, so they know body and mind aware, so they know what it should feel like, and progressing in appropriate increments, so you're not suddenly going from a sort of basic stand to throwing and catching, for example, which is really going to throw somebody out. You do it bit by bit, so it may appear very slow, but actually over time they'll make a massive improvement. But it is down to practice, and then as we've said before, feedback, so that they're getting some feedback from the therapist about what that looks like from a therapist point of view, but getting them to also think for themselves based on the feedback they're given, what that actually feels like, so they can then start to almost give themselves feedback.
And I think as well, you know, we all need to become a bit more mindful about including anxiety strategies and in our as part of our physical approaches. And going back to the oncology work that we've done, the fear, anxiety and breathlessness are big symptoms for a lot of patients with diagnoses of cancer, but equally so are they for other people who've not got that. So it's about us developing our skill sets as well. And if we're finding that we're working with more and more anxious patients, then we're going to have to develop skills to deal with those anxious patients and not just tell them to get a grip.
You're all right.
So it's, you know, our perception of how they're feeling. We need to listen to them and then work with them to overcome that.
Or even be able to pick up how anxious they are. Because sometimes people don't actually, they want to do what you're telling them to do. And so it's being aware of whether they're breathing really rapidly or suddenly gone really tense. And
so the non-verbal stuff.
Pointing that out to them, but maybe helping get them some strategies, like maybe to get them to concentrate on breathing, or just so they're not as anxious during the treatment.
But I do think it is, you know, like we've said before, it's a skill, you know, this is a toolkit. This is a tool in your toolkit, but don't forget all your other skills and all your other interventions in conjunction with it. So we'd hope that people would be empathetic towards anxious patients and not strap them onto it and, you know, leave them there. But we don't assume anything. We need to demonstrate it in action.
But people seem to be less anxious if they've got balance deficits and they're unsteady.
Absolutely.
Once they've felt that knee block, they do seem to be less anxious about doing things in standing.
Yeah.
It almost helps.
On a previous webinar, we talked about the sort of psychological capital, which talks about helping build hope, optimism, resilience, and sort of people in being able to see their goal. I just wonder, with all of your years of experience, what can you say around hope and optimism and resilience with the patients using Balance Active to prior to that?
Right. Okay. Well, do you know
That's what it's about?
It's
really,
absolutely about that, because you know, if
it's empowering them,
and it's about them visualizing what do they want to do, what do they want to be, and we can use Balance Active as part of that process to achieve that,
enable that.
And I think there's something in this about being realistic as well and honest. But then again, that's like any intervention. You wouldn't use an intervention if you didn't think it was going to make a difference. And that difference might be in enabling that person to undertake one task, or it might enable that individual to walk. So what are they hoping for? It's really important that we know that at the start of this journey, and what are their goals? And then you will prescribe Balance Active in the right way. And it's been a massive enabler.
We've got a really good case study coming up next week.
Oh, excellent.
You know, and you know, everybody's entitled to hope. And so it's just a way that manifests itself, and we have to be careful as therapists to make sure that we don't underachieve for people almost. Take the hope away.
Exactly. Good.
Does anybody have any more ideas then, apart from our lovely lady with ataxia? Or just
no, we haven't.
Any questions?
Otherwise, I'll just keep going, because I've got a list as long as your arm, so I can go bring them. So if you don't want to listen to me ask questions, ask some questions.
So are there any more questions anywhere there?
There aren't any more questions.
Not yet.
Not yet.
Coming.
Not yet. So I'm going to just keep you. No, I'll just keep you talking, ladies. It's fine. So I'm just curious, in all the years of your sort of experience, what was it that you suddenly, when you realised that Balance Active was the answer, how did that sort of thought process come about? Because that always intrigues me, is how you got to that piece of equipment.
I think Partly because of pragmatically having to use things like transfer aids, which don't really fit the bill, but also because we worked in the community for quite some time, and when you're working in the community, you're kind of restricted to the environment the person's in, and you're using whatever you can find around. And so a lot of the time you're getting them to hold on to something to do balance activities, but that immediately it sort of invokes they're using their upper limbs to balance with, and actually your upper limbs are used for function, aren't they? You need to be able to do things with your upper limbs whilst you're standing and balancing. Or for some patients, as James just said, you needed more than one therapist in there to support them. And it was like, and we had used things like, sometimes we'd get somebody stood with the knee against the sofa or something like that, and it wasn't always the right height and all sorts of things, but it kind of did at the time. And we thought, well, actually,
it was actually motor relearning that when we got more involved in motor relearning. And looked
to not invent something that
made it more normal,
made
that they could practice with. So,
because we've done that on, like in a clinic setting, you could adjust the plinth up and down and block somebody's knee on the plinth, but you can't take a plinth all over with you.
Even onto a ward. And I think as well, when we think about long-term conditions and the patients that you might have ended up using a big clunky standing frame that really just was great for range of movement almost, but not right to recruit anything.
So it's about self-management, empowering them to take some control of managing their condition.
Brilliant.
In a doable way that because we can't, actually, like Rachel says, the pragmatism, the gains that you were getting from one bit of it had something else that
just didn't quite work.
Just took the edge off what you're really trying to achieve. So suboptimal. And we've always aspired to do the best that we can for our patients, and so that made us think, right then, let's have a go.
Do some sketches.
Let's design one.
Okay. We have got a question. So I think Sharon's on it. So you're saved from another one from me.
So Sarah's asked, could a service trial a balance active for a short period of time prior to purchasing?
Absolutely. Yeah, absolutely no problem at all. We want real world evidence. We want people to try it and feel it and play with it.
Feedback to us.
Absolutely. So that's not a problem. I mean, we'd arrange for that to get delivered and then do a remote in-service training as part of that. And then there's some trial questions that we'd want, as part of that. So it's a formal process because we want to learn from it as well.
Yeah,
absolutely fine.
Yeah, fabulous.
What service is Sarah in?
I don't know. Sarah, where are you?
Tell us where you are.
Tell us where you are, Sarah.
Community Neuro.
Brilliant.
Southport.
Yeah, right, fine. Community Neuro sounds brilliant. And when you're thinking about the remote situation at the moment, and especially, I don't know if you're acute right through to self-management, but that would feel the perfect setting. Give us a team's call.
She's taking it to the team lead. You're brilliant. On it.
Nice. Perfect. Thanks, Sarah.
Brilliant. And it'd be lovely actually, Sarah, as well, if you do follow it through, which we hope you will, then you just let us know how you get on as well, because we'd love to share your case studies and stories as well, because we're all really keen just to learn, not just Sarah, Rachel and Jane, but we're all interested in really learning about how people are using different kits remotely, because that's it's our passion and our fascination. Okay, any last questions from anybody? No?
Is the case study in the case studies next week, will they show clients transferring from sit to stand if the balance active is a light touch? What we'll do, is actually the case studies are going to be week 4. Next week is a questions and answers session, we think.
It is, isn't it?
So it's the case studies of the last week, but we'll make sure that there's a sit to stand transfer within that.
We might do that next week, actually, because what we're going to do next week is just a group of us are going to come along and just spend some time with you guys and just talking about some of the challenges and the opportunities and the experiences that as therapists we all have. So that will be one of the things that we'd love to, I'm sure, is going to come up as a question, is how do you do that?
We'll make sure we'll get some footage for the case study.
Create a little
I'm just thinking who we might.
We could make videos.
Oh yeah. Watch
I've
out.
learned all sorts.
We're loving
thank
your
you.
home videos, ladies.
Yeah.
We're just loving it.
Oh God,
It only took 3 takes.
Anyway,
Yeah,
no, on a serious
brilliant.
note, and if they've got other things that they want to drop us a line about in between time, please do.
Yeah, get in touch with us.
Yeah. So if you want to also drop us a line as well, if you want to ask us through either our website or I think Carol's put some details where you can get in touch with us. If you've got questions and things that you'd like to explore, or you go back to your teams between now and our next webinar, and you talk to your teams and your teams have got any questions, then just let us know and then we can answer those questions, because I know the guys from Remote Rehab Community have got lots of questions for Rachel and Jane, and we could talk for hours. So if you want to get your particular perspective in and you want to get your ideas and your questions answered, then do let us know, and we'll make sure that we cover them. So I think we're nearly there. So I think we've got a minute left. Is there any other questions? No, I don't think so. So that just leaves us the opportunity just to talk a little bit about next week. So next week's an opportunity, really, we're just going to be looking at it from the therapist's perspective, aren't we? And we're going to be, there'll be a group of us who'll just be having a conversation about, from a therapist perspective, how Balance Active can be used with patients, but also we're just going to be having a broader conversation about balance and falls and all of the kind of ideas and thoughts that we've got around how to support patients. So it's going to be a very sort of more sort of informal conversation between a group of us.
And I think it'd be good if people bring to that examples of of kind of assessments that they're doing now and how they're translating that into remote. Because we talked about trying to collaborate to get some best practice guidelines together as a remote community. So that would be really good.
Yeah, brilliant. Well, thank you guys again. You've been amazing. I love listening to you guys. You're just so much fun. Thank you very much.
Yes,
Thank you. Great from Jane.
Thanks for having us.
Yeah.
Have a
We'll
good
see you
week,
next
everybody.
week.
yes, thank you.
Stay
Okay.
safe.
Thank
Cheerio,
you.
everybody.
Bye.
Good night.